Good evening, ladies and gentlemen. I would like to extend a warm welcome to all our colleagues that have joined us this evening for the third and last part of the series titled Diabetes Management in Dyslipidemia. This series is a part of the continuing medical education program offered by the Emirates Diabetes and Endocrine Society. This evening's webinar has been made possible with the help of our sponsor, Amgen. The logistics and technology support is being provided to us by the MCI group. We are thankful to Amgen and MCI for that. We have an outstanding faculty at hand to deliver a very interesting program, as you might have noticed from the agenda. So we do have a series of talks in the beginning, which will cover diabetes and lipid disorders and cardiovascular risk. Then we will have another one on, do we need to manage hypertriglyceridemia and low HDL in patients with diabetes? And then the third talk would be treat to target percentage reduction versus high dose statin. Is there a best practice? And this would be followed by question answers, and then the Amgen symposium about a new future of treatment of dyslipidemia in type 2 diabetes. So before we go on to our program, a few housekeeping items. This webinar is being live streamed on the Emirates Diabetes and Endocrine Society YouTube channel. The webinar is also available on demand on the EDES Institute website, and the address is there on your screen. For this evening, we would encourage you to send in to us questions and answers. Please type in your questions in the Q&A box and mention the speaker's name. If you have any technology-related questions, you can live chat with us for support on WhatsApp, and the number there is +971 5699 44287. This activity is credited by MOHAP for up to CME credit hours. So we now move on to our first talk of the evening. This is going to be on diabetes, lipid disorders, and cardiovascular disease risk. And our speaker is Dr. Ira Goldberg. He is the Clarissa and Edgar Bronfman Jr. Professor and Chief of the Division of Endocrinology, Diabetes and Metabolism at NYU School of Medicine. His research has focused on abnormalities of lipoprotein metabolism, macrovascular disease in diabetes, and the role of triglycerides in atherosclerosis. So I would now hand over to Professor Goldberg. Thank you.
So thank you. Let me do my share screen. Here we go. And do it on this. Oops. Let's see. Am I on full screen?
Not yet. If you can go back up to your first slide and then click on the full screen again, please. Yeah.
View. No, home.
Just come down to your first slide and then to the bottom where there is this, yeah. Right there. That's fine. Yeah.
Okay, let's go. Sorry. So what I'm going to do is talk to you from Manhattan about diabetes and cardiovascular disease. And it's going to be a little bit of an overview of how we got to where we are and some ideas on treatment, and hopefully a little bit of ideas on things that perhaps the other two speakers and I might agree or disagree on, which hopefully will be of interest to you. So I have a couple of conflicts. I do consulting for several pharmaceutical companies. So the objectives of this talk are to determine the pathophysiology of why diabetes increases cardiovascular disease, And to be straightforward, I can't really answer why this occurs, and neither can anybody else. I'll mention something about risk factors, many of which you already know. And then at the end, I'm going to talk about how you decide which medications to use. And it's wonderful that in the year 2021, we have a number of new medications and the opportunity to really treat our patients better and prevent either initial or recurrent vascular events in people with diabetes. And this will be a little bit of a topic that you'll hear from my colleague, Jamie Underberg, later on, a thought to reconsider whether the American Heart Association, American College of Physicians, and National Lipid Association idea that all people with diabetes, or especially diabetes risk, should be treated with high-intensity statins. And I think this is especially relevant to patients with prediabetes and metabolic syndrome. So here's the historic view of diabetes. So William Osler was the chairman of medicine at Johns Hopkins, and he was the physician of the late 19th century. And so I like to look back to see what people used to think. They used to think 100 years ago. So this is what Dr. Osler said about diabetes in his textbook. He said it's a disease of adult life, that it's a disease of higher classes, that the subjects have been excessively fat, that it's more common in the cities than in the country. And then 2 pages later, he said, the heart shows no characteristic changes. So some of these are still correct, and many of these are wrong. So what is somewhat correct is that it is a disease of adult life, but we're seeing much, much more type 2 diabetes in teenagers and young adults. And it looks like having type 2 diabetes and being a teenager is really a potent risk for cardiovascular disease. It used to be a disease of higher classes, but now actually it's the opposite. So in the mid-20th century, the wealthy businessman was obese or overweight because he had access to food, as did the people that Osler saw in 1900 in Baltimore, Maryland. But this is no longer true. In fact, type 2 diabetes is, at least in the US, more of a disease of lower classes than higher classes. Those are the people who eat fast foods and don't exercise a lot. So subjects have been excessively fat, and that's still true. It's not more common anymore in the cities than the country. In fact, we're seeing a lot of diabetes in countries. Back in 1900, the people in the country were farmers, they were thinner, they worked on the farms, and so they had less diabetes. The last statement is totally wrong, right? The heart shows no characteristic changes with diabetes. So how did the best clinician in 1900 totally miss the boat? He missed what our first-year medical students know, that the heart is really the organ that's affected by diabetes. So 3 decades later, Elliot Joslin got it right. He said with an excess of fat, diabetes begins, and from an excess of fat, people with diabetes die, because he already had made the connection, as did the rest of the medical community. So why does this happen? So there really were 2, and still are 2 major viewpoints. There's the sort of endocrinologist, diabetologist viewpoint that vascular disease or cardiovascular disease and diabetes is due to hyperglycemia or hyperinsulinemia. And then there's the sort of preventive cardiologist view that really this is not diabetes, but this is because people with diabetes, especially type 2 diabetes, have more hypertension and they have more lipid abnormalities, some of which you'll hear discussed by Dr. Norstegard in the next talk. So what have we learned? This is very old data, UKPDS, and but it's affected the way we think about diabetes and how to treat it. So shown in purple are the relationship from this group in the UK of hemoglobin A1C and microvascular disease, diseases of eyes and kidneys. And there's a very interesting sort of step ladder here. Because of this step ladder, you could imagine that as you drop the hemoglobin A1C, you will drop the risk of microvascular disease. And in fact, that's what's found in studies in type 1 diabetes and in type 2 diabetes. However, the relationship between hemoglobin A1C and macrovascular disease, mostly cardiovascular disease, looks totally different. It's much flatter. And you could imagine why it would be difficult to drop hemoglobin A1C and see a major impact. In fact, the most major impact between diabetes and cardiovascular disease and no diabetes is actually at the very beginning of the curve. And then it's pretty flat. So this is going to be a hard nut to crack, hard to show that lowering hemoglobin A1C really makes a difference. UK PDS looked at other risk factors. And in fact, hemoglobin A1C and its relationship to cardiovascular disease came out third on the list. Far away above those two things were the relationship between LDL cholesterol and HDL cholesterol. So the way to affect cardiovascular disease, as we've learned from clinical trials, is better to affect lipids than it is to affect glucose control. However, in type 1 diabetes, that's probably not totally true. So investigators and clinicians have asked for years, is glucose alone vasotoxic? And some people think glucose or ambient glucose is the toxic substance, and that's reflected in hemoglobin A1C. But other data think that it's not exactly glucose, but it's the variability of glucose. So you could have prediabetes, and you could have an absolutely normal hemoglobin A1C or a slightly elevated one, but a marked increase in glucose excursion after a 1 or 2 hour glucose tolerance test. And that excursion or variability of glucose is also reflected in what we can now gather in people's continuous glucose monitors. So maybe it's glucose, or maybe it's glucose variability that's toxic. So this is the classic study that was done in type 1 diabetes. It's the EDIC trial from DCCT that basically showed that after 14 or 15 years, people with type 1 diabetes who had tighter control, and tighter control only during the first 7 years of this study, had markedly less cardiovascular disease. In fact, they had half the cardiovascular events of people who during those first 7 years were not treated, even though at the end of this trial, hemoglobin A1C was the same between the two groups. I think the most impressive thing about this trial actually is that the event rate is decreased by 50%. 50% is actually better than any lipid lowering or statin trial has ever achieved. So this is remarkable, and is the reason that people with type 1 diabetes, the major way to treat them and the major way to decrease cardiovascular events is to treat their glucose. So investigators have wondered how to understand that relationship. So people with diabetes get much more cardiovascular disease. And that's also reflected in studies that are done in several animal models, like the porcine model. However, in mice, this relationship doesn't clearly happen, partly because mouse atherosclerotic models are associated with very high cholesterol levels. And in most of those models, the high cholesterol actually trumps the diabetes. It means that the vascular disease sort of correlates with the level of cholesterol, but not the level of diabetes. Dr. Norstegard loved the last one, which is the studies that he did and others have done in rabbits. So actually diabetes in rabbits is associated with less cardiovascular disease because the rabbits develop very large lipoproteins, which he and others have shown are unable to enter the vascular wall. So even with diabetes, if you don't have an atherogenic lipid profile, you do not get atherosclerosis. Probably even more important in 2021 is not the development of atherosclerosis, but the regression of atherosclerosis. So we have known since the 1950s in animal models that if you raise cholesterol, people will get animals will get vascular disease. This was shown in rabbits, it was shown in pigs, it was shown in mice. On top of it, though, we know that if you then lower cholesterol levels, the blood vessels repair. They'll repair meaning that the lipid will come out of the wall of the blood vessel, the white blood cells will decrease, the vessel wall will get scarred, so the lumen will not change that much. In fact, the plaque size doesn't change that much, but the biology of the plaque will totally change. And we now know that the same thing will happen in humans, that 2/3 of humans who get LDL cholesterols below 70 will be in the regression phase of atherosclerosis. So 2/3 get regression with high-dose statin treatment. Who doesn't get regression? So this is a study from the center of this study was Cleveland Clinic. The bars going down show the amount of regression that they found using intravascular ultrasound, sort of an ultrasound to look at the lumen and plaque size, mostly the plaque size. And if you look at the people without diabetes compared to the people with diabetes, and you compare the LDL cholesterols, you can see that diabetes is what prevents regression. Not the only thing that prevents regression, but diabetes affects regression. And this is true in humans, and this is true in animal models. That diabetes causes some changes, perhaps to white cells, perhaps to endothelial cells, perhaps to circulating other factors, and it prevents blood vessels from remodeling, even though you lower LDL cholesterol. Okay, so high-intensity statins are the treatment of choice for people with vascular disease. And high-intensity statins are recommended by the American Heart Association and several other organizations to actually treat people with diabetes or people who have metabolic syndrome but appear to be at increased risk, meaning they have hypertension, they have lipid abnormalities, they have some other reason for risk. The problem with high-intensity statins are that if you give them to people with pre-diabetes or metabolic syndrome, some group of those patients will switch from pre-diabetes or metabolic syndrome into real diabetes. The vascular biology community, especially the cardiologists, had said, okay, well, that's okay. For every 54 cases of new diabetes from Jupiter, 134 vascular events or death was decreased. In other words, you've decreased cardiovascular disease twice as much by putting people on high-dose statins, even though you will cause some diabetes. I will argue that you probably could get the same amount of LDL reduction. In fact, I know it. If you put somebody on a low-dose statin where you don't have the risk of cardiovascular disease and you add another drug, for example, ezetimibe, Dr. Underberg in the third talk will readdress this, and he'll address it in a viewpoint of somebody who's primarily a preventive cardiologist. And that differs from somebody like me because I have to take care of the diabetes too. And diabetes doesn't only cause cardiovascular disease. Okay, so insulin reduces cardiovascular disease in type 1 diabetes. Lower glucose reduces risk, but not mortality in most of the studies in type 2. We'll talk about the new drugs in a minute. The reasons for increased heart disease and diabetes are really unknown. People with diabetes have more lesions. The lesions look a little less stable. They may be more inflammatory, as maybe glucose or insulin resistance modulates macrophage biology. But other risk factors also matter. High triglycerides and HDL, which you'll hear about in the next talk, hypertension, renal failure, and maybe on the top, obesity. So our history of treating diabetes, or at least treating diabetes to reduce cardiovascular disease, has had a major change in the last 2 decades. So I'm going to tell you about the history of SGLT2 inhibitors a little bit. These are ancient drugs. They were first discovered in the mid-19th century by German chemists. And I'll tell you a little bit what the history of those drugs are and how they make sense to use. The other major change in our treatment for people with type 2 diabetes is the development of GLP-1 receptor agonists, and the evidence that those 2 drugs really affect cardiovascular disease was driven by a US FDA mandate in 2808 that said to pharmaceutical companies, not only do you have to develop drugs that lower glucose, but you need to show what they do to cardiovascular events. And both those drugs have cardiovascular protection. So Forazine is a relatively old drug, was initially isolated from the bark of the root of the apple tree by German chemists. They thought this would be sort of like aspirin, which also comes from willow bark, and they actually used it to try to treat the symptoms of malaria. And what they found was when they gave a large amount of this drug Forazine to humans, they developed glycosuria. But in 1900, when Osler was around, glycosuria and diabetes were not clearly understood to be separate diseases. So in fact, they thought that the drug caused diabetes because glucose spilled in the urine. Subsequently, physiologists learned that actually Forazine actually decreased hyperglycemia, and it did it by causing increased glucose to go into the urine. The other thing that we learned is about 2 decades ago, a family was discovered in New Haven, Connecticut, that had a defect in the receptor that Forazine hits that we now know as SGLT2. And that family with the molecular defect had lots of glycosuria, but otherwise was totally healthy. So why was this especially important to diabetes? So this is an old paper, right now 70 years old, of a clinical study that was done at my medical center by Saul Farber, who used to be the dean of the NYU Medical School. And what Dr. Farber did is he took people at Bellevue Hospital, he infused glucose into it, and he realized that hyperglycemia changed the renal threshold for glucose. And the old diabetologists knew that. So they would have patients whose glucose was 250 who didn't spill glucose in the urine, where a normal person would spill glucose at about 180. What Dr. Farber didn't know was he caused the upregulation of SGLT2. So SGLT2 is in the proximal tubule. It causes the absorption of glucose and the absorption with it of some sodium. If you block that receptor, glucose goes in the urine, as does some sodium. So it causes some dehydration, some drop in blood pressure, but it normalizes or decreases glucose levels. Those of you who really take care of a lot of diabetes know that the way to lower glucose, for example, in somebody with DKA, is to replete their renal filtration so that the glucose goes in the urine. The treatment of DKA is insulin to prevent the acidosis in fluids to lower the glucose, because this is the way you lower glucose, is you put it out in the kidney. So I'm sure all of you or many of you use these drugs. So these are now almost first-line drugs in type 2 diabetes, because a whole series of studies have shown that they decrease cardiovascular events. And the major event that they treat is actually heart failure. And these drugs now are first-line treatment for people with heart failure, even those who do not have diabetes. The second new drugs are the GLP-1 drugs. So this kind of study was done in the 1960s, actually at Washington University, where Dr. Kipnis gave glucose intravenously and orally. And he found that if you gave glucose orally, you got a much higher insulin response. And he came up with the idea that there was something called incretin, something released from the gut when glucose was there, that drove insulin up. And we know now one of those incretins is the hormone GLP-1. So how can you increase GLP-1 in the gut, in the body? And if you do that, do you increase insulin release? So there have been two pharmaceutical approaches to that. One has been to use a series of drugs called DPP-4 inhibitors. What these drugs do, and they're listed there, is they block the degradation of GLP-1 in the bloodstream. So GLP-1 goes up, not as much as giving an injection of it, but it goes up and it lowers glucose. The second way to increase GLP-1 is to give GLP-1. And then there's a whole series of GLP-1 receptor agonists. These are primarily given by injection because they're small proteins. And they're probably standard therapy that you are using. A new form of one of these, semaglutide oral, has also been released, in which people take a pill and there's a mechanism to allow the GLP-1 to get into your system without an intravenous injection. We have less data on that therapy, but that's around also. So what do these do to cardiovascular disease? Well, the DPP-4 ones, I could show you probably 100 slides, but this is the story. They lower glucose, but they make no effect on cardiovascular disease. So they're good to lower glucose. Presumably the lowering of glucose will prevent microvascular disease, but they do not affect macrovascular disease. In contrast, a whole series of trials have now shown us that the other drugs, the injectable GLP-1 drugs, really make a major difference. They reduce all kinds of cardiovascular events. They reduce heart failure some, but they mostly reduce vascular disease. Why they do that is not totally clear. So this is one thought. So one of the causes of increased disease in most people with type 2 diabetes really stems from obesity and a condition we call lipotoxicity. So as you get fatter, the fat sort of redistributes. Some of it goes to the liver and causes liver failure or fatty liver. Some of it goes to the muscle, and many people think that's the major cause of type 2 diabetes, the fat in the muscle causing insulin resistance. Some of the fat goes to the heart. Maybe it affects vascular disease, and it certainly affects heart function and probably cardiomyopathy. So this is the problem we're dealing with in the US, and we're dealing with around the world, probably in places where you are. That most of the population is now getting too fat and too well fed. This sort of cartoon suggests that the only two places in the US that are not so fat are Southern California, where everybody goes to the beach. Maybe Dubai also, people are interested in getting to the beach. And for some reason, Manhattan Island. So this is what the GLP-1 drugs, and this one turns out to be the best, at least right now, the best or the best data. So this is a recent New England Journal paper from a few months ago, and it showed that if you took people and you treated them with a GLP-1 receptor agonist, semaglutide is the drug they used, you get a marked reduction, average reduction in weight. All of these drugs cause weight loss. This one looks like it's the best. This 16% weight drop over the course of about a year, a little more than a year, is almost what people get with bariatric surgery. So in fact, our approach to obesity has changed, that semaglutide or GLP-1s are now first line, probably for obesity, probably for insulin resistance, and probably for treating people with type 2 diabetes who had risk of cardiovascular disease. And the weight loss may be the reason that these drugs have cardiovascular benefit, because studies have been done just doing bariatric surgery, and bariatric surgery also markedly reduces cardiovascular disease. So sorting out whether the effects or the benefits of the drug are exclusive of the effects of weight hasn't been figured out yet, and maybe never will be. Okay, so how do you decide which of these drugs to use? You have a drug that causes renal wasting of glucose that you can take as a pill. And then you have a drug that you can take as an injection and has better cardiovascular vascular benefits. And it also causes weight loss. So a number of years ago, we looked at this and we said, gee, you know, if you have a patient with type 2 diabetes and they're on metformin, and it's not clear metformin should be the first line drug anymore, but if they are, you should divide them up. If you think they're at more risk of heart failure, they have hypertension, they have cardiomyopathy, then probably your next drug is an SGLT2 drug. If you're more worried about vascular disease, or if they have vascular disease, you maybe should go the other way. Think about using a GLP-1 agonist drug. You should know if somebody is thin and not obese, a reasonable drug is to use something like pioglitazone. You'll hear more about this probably in the next talk on triglycerides, because this drug looks like it also has vascular vascular protective benefits. So when you see your patients, you have to think about cardiovascular disease, diabetes, and what that particular patient might have as side effects. I've made an argument that although high-intensity statins do reduce cardiovascular events, and certainly do it better than low-intensity statins because they lower LDL more, you could lower LDL by other means. And perhaps that makes sense because you reduce the risk of giving somebody diabetes and having to take care of their diabetes as well as having to take care of their cardiovascular risk. SGLT2 inhibitors, they have risk. People get diabetic ketoacidosis on it, especially people on low carbohydrate or ketogenic diet. They get fungal infections, especially women. And so you need some prevention there. And over the summer or in Dubai, when it's really hot, they have a risk of hypertension as the drugs cause a little bit of dehydration. They also increase urinary infections a little bit. The GLP-1 receptor agonists, their negative is that they're an injection. They have a warning for pancreatitis. So if somebody has pancreatitis risk or really high triglycerides, I might not use them. And they cause GI discomfort or reflux, and that's an issue for patients. And so on each patient, you'll have to make some decisions on which of these therapies to use. So take home. Diabetes associates with risk of heart failure and vascular disease. GLP-1 is better for heart failure, is better for SGLT2 is better for heart failure, GLP-1 better for cardiovascular disease. All drugs have side effects. Think about them when you decide which drugs to give to your patients. And I will stop there and stop my share.
Thank you, Professor Goldberg. We probably will have some questions during the question and answer session for you. So we would appreciate if you are here with us till that time. So moving on to our next topic. This is, do we need to manage hypertriglyceridemia and low HDL in patients with diabetes? Our speaker is Professor Børge Nordesgaard. He's a professor at the University of Copenhagen in Denmark. He's the chief physician, Department of Clinical Biochemistry, Erlev and Gentofte Hospital in Copenhagen, at the Copenhagen University Hospital in Denmark. He has decades of experience, and his interest is in the pathogenesis, diagnosis, and treatment of hyperlipidemia, atherosclerosis, diabetes, and cardiovascular disease. And he has written extensively and published on this topic. So I'm going to now hand over to Professor Nordesgaard.
So thank you very much for this very kind introduction. I will now share my screen. I think everybody should be able to see it. Is that right? If that's the case, then so my name is Børge Nordesgaard. I'm a professor and chief physician at Copenhagen University Hospital. I'm also a professor at the University of Copenhagen, and all my disclosures are shown here below. So the title is here: Do we need to manage hypertriglyceridemia and low HDL in patients with diabetes. And I think I'll start with the conclusion. Do we need to manage hypertriglyceridemia? Yes. Do we need to manage low HDL? No, in patients with diabetes. Here's how I look upon the various lipoprotein classes, the major ones, HDL being the smallest ones, mainly carrying cholesterol, LDL being a bit larger, mainly carrying cholesterol, shown here in yellow. And then we have the remnants or VLDL or triglyceride rich lipoproteins. So they have a lot of triglycerides, but also a lot of cholesterol. And then finally, lipoprotein little a. All these three collectively are called ApoB containing lipoproteins. Many people thought that HDL could take cholesterol away from the arterial wall, but this hypothesis is gone now. There has been so many failed randomized trials of raising HDL, so I think only very, very few people believe that again. So my best advice to you is, when you look at it clinically, forget about HDL cholesterol. Of course, if HDL is very low, it's a marker of high risk. So I don't more call it good cholesterol, I call it the mysterial cholesterol. And the three remainder, LDL, of course, we know causes atherosclerosis, mainly stable plaques. And then we have the remnants, or the VLDLs. And they seem to also cause atherosclerosis, but maybe particularly inflamed, unstable plaque. I'll show you some data for that. And then finally, we have lipoprotein little a, where many tend to think it causes atherosclerosis, just like LDL, because it has an LDL particle within it. However, most people have very little cholesterol in Lp(a) compared to LDL. So in my mind, it is also quite possible that Lp(a), through this extra protein ApoA, interferes with fibrinolysis and thereby indirectly thrombosis if you have a plaque rupture at an inflamed, unstable plaque. These things, of course, leading to atherosclerotic cardiovascular disease, myocardial infarction, or stroke. When you take a blood sample and take away the red blood cells, then you have these three different ways plasma can look like. It can be yellow, partly due to cholesterol. Then you would have high LDL. You could also have high Lp(a), in that case, high cardiovascular disease risk. And then you have the turbid plasma, where you have somewhat high triglycerides, maybe from 2 to 10 millimoles per liter, so that means up to about 900 milligrams per deciliter. Then you have high triglycerides, high remnants, and in that case, particular high risk of cardiovascular disease. And then you have the very extreme situation where there's a lot of fat in plasma. So this patient has about 9% of all plasma is pure fat, or 110 millimoles per liter. Then you have chylomicronemia, very, very high triglycerides, and high risk of acute pancreatitis. And these are the two types that you see in patients with diabetes. Most patients, just a little bit elevated triglycerides, and then the rare case of completely dysregulated type 1 or type 2 diabetes with chylomicronemia syndrome. And here's, of course, the extreme situation with eruptive xanthomas, as here on a patient I saw, which has high risk of acute pancreatitis. I'm sure many of you have seen these in your clinic. And here's close-up eruptive xanthomas. This is really chylomicrons, triglyceride-rich lipoproteins coming into the skin, causing local inflammation. And then you can envision also coming into the pancreas at the same situation. And then because there's lipase in pancreas, maybe thereby causing acute pancreatitis. So away from the chylomicrons, otherwise we have these three lipoproteins. So LDL, Lp(a), similar size, except that Lp(a) has this ApoA on top of it. And then we have these somewhat larger lipoproteins, remnants, VLDL, or triglyceride-rich lipoproteins. It's the same. Here I try in a simple way to show in a cartoon as plasma triglycerides go up, both on a scale from milligram per liter and millimoles per liter. And notice these are pretty high values already here. Then in the beginning, you only have very small lipoproteins, LDL, and then at some stage you start getting the VLDL remnants. And of course, in triglycerides is very high, you also get the chylomicrons in plasma. It seems like from when I review the entire literature that risk of both acute pancreatitis and myocardial infarction go up. And at one stage, as Aya Goldberg just mentioned, then the risk of myocardial infarction will go down, probably because these lipoproteins are too large to come into the arterial wall. Here's what we usually measure in the clinic when we try to get a full picture of the lipoprotein profile. So a standard lipid profile is plasma total cholesterol. It's cover all these 4 fractions. Plasma triglycerides covers all these 4 fractions, but we usually take it as a marker of the remnants of VLDL. We also measure HDL cholesterol directly and LDL cholesterol directly. Note that Lp(a) cholesterol is actually within the LDL cholesterol. And then we have the remnants. And I have for years, and try also even in my own country, we use this calculated remnant cholesterol. So you take total cholesterol, this value over here, and you subtract the LDL and HDL cholesterol up here, and then you just have the cholesterol in the remainder, the remnants. That's because I think there's strong evidence that particularly the cholesterol in these particles is what causes atherosclerosis in hypertriglyceridemia. Many guidelines and clinicians also talk about non-HDL cholesterol being a composite of LDL, Lp(a), and remnants. But of course, if these have different functions of causing disease, maybe one can be a bit fooled by that. But these are also fine to look at. So triglyceride-rich lipoproteins cause atherosclerotic cardiovascular disease. Here's just some data from our own study, what's called the Copenhagen General Population Study, with roughly 100,000 individuals. And here on the same scale, I put an increase in LDL cholesterol of 39 milligram per deciliter or 1 millimole per liter. Side by side in the same individuals, 1 millimole per liter increase in remnant cholesterol and the same increase in Lp(a) cholesterol. I'm not saying that it's the cholesterol in Lp(a) that causes the disease, but this is just to put them on the same scale. So as you can see, for the same increase in LDL cholesterol, this is the risk hazard ratio for myocardial infarction. But if you have the same increase in cholesterol and remnants, the risk is higher, and it is yet higher for Lp(a). Then there's also the genetic estimates shown here. And what they show is that they have wider confidence because there's not statistical power, but because they are on the right side of the observational estimates, they show that all these 3 are causally related to cardiovascular disease, and they are independent of each other because they are adjusted for each other, and also because of the genetic evidence. One thing that really convinced me as a young clinician working in lipid clinics was to see these patients with what's called remnant hyperlipidemia. It's also called type 3 hyperlipidemia or dys-beta lipoproteinemia. This is the condition with ApoE22 genotype and some other conditions. And then they have these Palmer-Crees xanthomas where cholesterol is positive, and also tuberoeruptive xanthomas that are different from the eruptive xanthomas I showed you before. What's particular about this is that they had accelerated atherosclerosis and premature cardiovascular disease as much as familial hypercholesterolemia. So this is a genetic cause of high remnants in plasma. They get very severe atherosclerosis. And here's another piece of type of evidence, namely from what's called the TNT statin trial. And here, what is shown here, this is for the group major cardiovascular events in patients receiving 10 milligram atorvastatin. And then here they put that group into 5 different groups with the lowest to the highest remnant cholesterol. They call it triglyceride-rich lipoprotein cholesterol. But the essence is that it's only the ones with high triglyceride-rich lipoproteins when on a statin that have increased risk of major cardiovascular events. The ones that had low remnant cholesterol did not have increased risk after getting a statin. And then here just ordinary epidemiology in our own studies, 100,000 people, 3,300 events. We followed people for up to 30 years as single non-fasting triglyceride measurements. The reference being the ones that had less than 88 milligram per deciliter, and then higher and higher risk just from a single measurement of non-fasting plasma triglycerides. Here above 528 milligram per deciliter or above 6 millimole per liter, they had a 5-fold risk of myocardial infarction. And I tried on this slide in a paper co-authored with Parhofer and Chapman to show that from all our data in Copenhagen, when triglyceride goes up, and he also showed for non-fasting remnant cholesterol, which of course is the cholesterol content in the triglyceride-rich lipoproteins, then there's a steep increase in all these events. So pancreatitis actually goes up the most, but the absolute risk of pancreatitis is lower. And then myocardial infarction is the most important in stroke, all-cause mortality, and even aortic stenosis, whether you look at plasma triglycerides or remnant cholesterol. What is the mechanism, including inflammation from these lipoproteins? So here in a review together with an Envabo that I did lots of the research together with, you can see here that in plasma, when you have LDL remnants and chylomicrons, then as Dr. Goldberg already mentioned, then the chylomicrons are so large, they are not able to enter into the arterial intima. However, both LDL and remnants can come into the arterial intima. And while we know that LDL needs some sort of modification before they can cause atherosclerosis, then remnants are well known to maybe act much faster. Indeed, lipoprotein lipase at the surface of these particles will liberate free fatty acid and monoacylglycerol. These are toxic to tissue and cause local inflammation. And also, we know that remnants can be taken up directly by macrophages to cause foam cells without being modified. Here's some data, Signe Hansen from my group, trying to show that when we looked at 116,000 individuals from our 2 Copenhagen studies, as plasma triglycerides go up, how much does plasma C-reactive protein go up in a normal population, people living in the general population? And you can see there's a steep increase in C-reactive protein up to roughly 5 millimoles per liter. Then C-reactive protein goes up. And then within exactly the same individuals, we did exactly the same analysis, but now we have plasma low density lipoprotein, LDL cholesterol. And here, there's no increase in CRP when LDL goes up. People thought that in the past, but this is not true. It's the triglyceride lipoproteins that is associated with very high C-reactive protein. So how I try to depict this in a simple way to understand is that when you have triglycerides, most prominent, of course, when you have chylomicronemia syndrome. Here's a triglyceride molecule. Lipoprotein lipase will degrade it to free fatty acid. This will lead to local inflammation wherever it is because free fatty acids are toxic to tissues. If that happened in the pancreas, maybe acute pancreatitis. If you have less elevated triglycerides, where you have VLDL or remnants, then you still have triglycerides. So you can still have the triglycerides go through the inflammation. However, here you also focus on the cholesterol content that will lead to foam cell atherosclerosis and myocardial infarction. And maybe the combination of some of this local inflammation in atherosclerotic plaque is what triggers a plaque rupture and acute coronary syndrome. Here's some novel data I'd like to share with you. Mia Balling just published in November of 2020 in JACC, where we tried to tease out using the Copenhagen studies, is it the cholesterol content or is it the triglyceride content of the remnants or VLDL that is most likely to cause myocardial infarction? So as you can see here, as VLDL cholesterol goes up, the hazard ratio for myocardial infarction increases, and here's the confidence interval. This is the distribution in the population. When you look at the triglyceride content in VLDL measured by metabolomics, then risk does go up as triglycerides go up, but then it levels off. For comparison, when you look at IDL cholesterol and LDL cholesterol, just like VLDL cholesterol, the higher the concentration of cholesterol in these fractions, the higher the risk of myocardial infarction. We also did a so-called mediation analysis, trying to see what's the explained risk from all ApoB-containing lipoproteins to myocardial infarction. And there we could show that when you looked at all ApoB in plasma measured as total plasma ApoB, then of the risk of myocardial infarction, 50% or half could explain by VLDL cholesterol. I think this would be surprised by many. Nobody has tested it before in such a large human study. And only 29% by IDL and LDL cholesterol, and nothing was explained by the VLDL triglycerides. Here's another study that we just published this year. We tried to understand that when you have obesity, how much of the excess risk from obesity, that also means from diabetes, of course, is explaining the increased risk of myocardial infarction. And here we tried to do this. So this is the mediated excess risk in the association between BMI and risk of myocardial infarction. And the cholesterol in all VLDL could explain 40%. If you split VLDL up in two fractions, it was similar fractions. But again, surprisingly, when people get very obese and thereby many of them having diabetes, it's not the cholesterol IDL, it's not the cholesterol LDL that mediates the risk of increased myocardial infarction, but VLDL cholesterol. Hypertension, systolic blood pressure explained 17%, and diabetes explained 9%. And here we did a very detailed metabolomic study in about 30,000 individuals from the Copenhagen General Population Study, from 10 different fractions, from the smallest LDL to IDL to smallest VLDL to the very largest VLDL. And here you see the different sizes and the different relative content of cholesterol in yellow and triglycerides in gray. And note that when you look at how many particles in these individuals was present, this is percent of particles. So most has LDL, but still a lot had small VLDL and very few had the very largest VLDL. But if a patient had these very large VLDL that you typically will see in dysregulated diabetes, then they had a hazard ratio of myocardial infarction much, much larger than for LDL. And so this is a hazard ratio for myocardial infarction per the same number of particles. So for the same particles, VLDL, particularly large one, are most dangerous for causing myocardial infarction. And here's a last paper I'll show you from recently published just a few months ago in JACC, where we tried to test ApoB and non-HDL cholesterol are better reflections of residual risk than LDL cholesterol in statin-treated patients. So what we really did was that we took 13,000 individuals, and of those 2,500 died, and then we looked at all-cause mortality, and then we saw what is the association with ApoB. They were all statin-treated, and you can see that the risk of dying went up as ApoB concentration went up. The same was the case for here myocardial infarction. There's this strange thing about risk goes up when ApoB is low, but that's a different story. When we then compare with, this is non-HDL cholesterol. As non-HDL cholesterol goes up, it is the same, then all-cause mortality increases, and so does risk of myocardial infarction. However, very surprisingly, because it's in all the guidelines, when you look at LDL cholesterol in statin-treated patients, risk of all-cause mortality did not increase with increasing LDL. Risk of myocardial infarction did not increase with increasing LDL. It was the non-HDL cholesterol, which is LDL, together with the remnants. And so we did this discordance analysis where we tried to, within now looking at all-cause mortality, the reference being the individuals with low ApoB and low LDL cholesterol. And then compared to the ones that had low ApoB but had LDL cholesterol above the median, they did not have increased risk, if anything, lower risk. But the ones that did have increased risk of dying were the ones with high ApoB but with low LDL. And the difference here, of course, is that they have high triglyceride rich lipoproteins, increased risk. And if both were high, they had increased risk. And when you look at now myocardial infarction, in the reference, both ApoB and LDL low, if only LDL is high, there's no increased risk of myocardial infarction. However, if only ApoB is high, there's a high risk of myocardial infarction, and the same if both are high. So summing up this paper, where you can see, usually we just look at LDL, but here, when you look at non-HDL cholesterol, it's LDL, Lp(a), IDL, VLDL, and actually also chylomicrons in the smaller forms. And then they all have an ApoB, so ApoB will also capture all these fractions. So our discordant analysis showed that when LDL was high and non-HDL cholesterol or ApoB were low, there was no increased risk or mortality or myocardial infarction. But when LDL was low and either non-HDL cholesterol or ApoB was elevated, there was from 18 to 20% increased risk of mortality, 49 to 78% increased risk of myocardial infarction. When LDL was low and both were high, the risk was even higher, 23% higher risk of mortality, 82% increased risk of myocardial infarction. Fasting versus non-fasting. So in the fasting state, you have the liver producing VLDL, lipolyzed to degrade some of the triglycerides. You have IDL, LDL, and LDL is taken up by the liver or peripheral cells. While in the non-fasting state, you in addition also have chylomicrons from the intestine going into the bloodstream, lipolipase with degrades triglycerides and comes back to the liver. What we call remnant cholesterol is a composite of all these here. So in the non-fasting state, you capture not only the fasting lipoproteins, which are plenty present in the fasting state, but also the chylomicron remnants and even more VLDL being turned out. So just to illustrate, in my little country, Denmark, it's up here in the northern part of Europe, in Scandinavia. What we do with laboratory practice is that fasting, we only have two things. One thing left we use fasting for, this is an oral glucose tolerance test. We do not use fasting glucose, we just use hemoglobin A1C for diagnosing diabetes. So all other blood samples are non-fasting. And to the best of my knowledge, fasting does not improve clinical practice. It's just old-fashioned. And this is, I'm trying to illustrate here that a non-fasting lipid profile, this is really a 24-hour circle where you see people mostly have breakfast and something in the, before lunch, then they have lunch, then they have maybe something in the afternoon, they have dinner, and maybe something while watching TV or something else. And then fasting is usually defined as more than 8 hours since the last meal. So fasting will only be here 1 hour. So the most normal thing is non-fasting. And there's lots of argument for this being evidence-driven. In the fasting state, we ask patients to come in up in the morning. Sometimes they maybe been fasting for several hours, and then we test a fasting lipid profiles. And in the best of my mind, this is only driven by belief. This is what we used to do, and therefore we keep doing it some places in the world. The big guidelines in the world now, both the American lipid guidelines and the European guidelines, they say, please use non-fasting lipid profiles. And the only thing that really changes is what I illustrate here with some data from our Copenhagen studies, here's fasting, and then up to 3 to 4 hours after the last meal, you have a little bit increase in triglycerides, therefore a little bit increase in remnant cholesterol, so you better capture risk here. How common is it? Well, here's a distribution in a Copenhagen population. It's very similar in America and many other populations, I'm sure also in the Middle East and maybe in Indian places, with a trend toward even higher triglycerides. So here's plasma triglycerides. It's a skewed distribution with tail toward higher levels. So from 2 to about 11 millimoles up to 100 milligram per deciliter, it looks like this, 27% of the population, and only 1 in 1,000 have really white plasma. The most important determinant of high triglycerides and high remnant cholesterol is shown here, and this is body mass index. So here we have 100,000 people, so there's about 10,000 in each of these groups. The highest versus the lowest body mass index, and this is the remnant cholesterol. And you can see as you have more fat in the body, you have more fat in the blood. So R square of 12% is a lot. The green ones are what's usually considered within the normal weight range. This is usually the overweight, and this is usually obese. So for any increase in body fat, there's more fat in plasma. And here I try to show it very simple so that anybody can understand it. If you have a low caloric fat intake like this is an Indian meal, then you will look like this, and you will have normal blood, you will have normal liver, and you will have a normal heart. If you have a high caloric fat intake and you look like this, you probably eat something along these lines, then you have fatty blood, then you will also have fatty liver, and then you will also have fatty heart and thereby myocardial infarction. Treatment. Please remember to exclude secondary hyperlipidemia. I'm not going into that, but of course, dysregulated diabetes is a very important one. Otherwise, what you want to treat when you have high remnants of triglycerides, that of course is to try to convince the patient to eat less or exercise more. And we all know this is very difficult, even when you try to convince yourself to lose a little bit of weight. And then it's very essential to treat diabetes optimally for glucose control, because high triglycerides and high glucose are related. And then, of course, there's a lot of alcohol intake, try to reduce that. Otherwise, high intensity of statin, we heard Dr. Goldberg has some arguments against it, but still, I think for the majority of patients, this is what you want to do. And then there's this new evidence, icosapent ethyl, EPA, and then fibrin. And you should not use fish oil over the counter. This is not well shown. So from the European guidelines, ESC/EAS guidelines 2019, Francois Marc published in 2020, what they say about recommendation for drug treatment for hypertriglyceridemia is that class 1B is statin treatment. This is what you should use, and that's if triglycerides is above 2.3 or 200 milligram per deciliter. Then you can, in some circumstances, in high-risk patients with triglyceride levels between 1.5 and 5.6, use despite statin treatment, you use N-3 PUFA icosapent ethyl 2 times 2 grams per day. This is because of the reduced trial. And then there's also some situation where they advise fenofibrate or bezafibrate with less weight compared to the other two ones. So here's the evidence for using statins, a meta-analysis in 2016, where it shows that what's the mean change in plasma triglycerides in people that on average had 248 milligrams less than triglycerides, or 2.8 millimoles per liter. And you can see that atorvastatin 80 milligram and rosuvastatin 40 milligram, they both reduce triglycerides about 30%. And remember, at these doses, they reduce LDL at 50% at the same time. So they do both things. And therefore, I'm a strong believer that we should use high-dose, high-intensity statins when triglycerides is elevated. That's the best evidence base, or you can alternatively use the middle dose, not the lower doses. For fibrates, here's a meta regression that I did together with Warburg in 2014, taking all the different fibrate trials. And I think many talk about the fibrate trials are negative, but when you actually look at this scale, how much did you reduce triglycerides in millimoles per liter? And what was the reduction in cardiovascular events here from 1 and down? So you can see the more you reduce triglycerides with fibrate, the more reduction you have in major cardiovascular events. 24% reduction per 1 millimole triglyceride reduction, 88 milligram per deciliter. And then there's this new trial. So there's the reduced trial using icosapent ethyl 4 grams daily versus mineral oil. And here, this is debated a lot because it's mineral oil. And could mineral oil have a deleterious effect, explaining some of the difference? But the results are extremely clear. Icosapent ethyl, 23% patients had an event, and the untreated 28%. So remember, there's 1 in 3 get an event untreated at 5 years. So that's a hazard ratio of 0.75. And that means that number needed to treat to prevent one is 21, highly significant. So at this drug, triglycerides reduced 20%, CRP 40%, and LDL 7%. I don't think it's triglyceride that explains the whole, but it will probably explain a little fraction of the effect. And then there's the very surprising strength trial that was published in 2020 in JAMA. And so you would say from the surface, very similar results, very similar studies. The only thing that omega-3 fatty acid was a composite of EPA and DHA, while the reducer was EPA only. But here, the comparison was corn oil that could be beneficial. So that could be explained part of it. Here we saw a 18% triglyceride reduction, a CRP reduction of 11%, and LDL of 3% increase. This is probably not important because triglyceride abundance went down. And then also a word about low dose omega-3 fatty acid. You would think like you could over-the-counter fish oil if you use that. But here's a meta-analysis of 10 trials involving 78,000 individuals in randomized trials. And bottom line is that when you compare low-dose omega-3 fatty acids versus controls, there's no effect. It's a hazard ratio of 0.79, and that's the same when you look at different endpoints. And then when you look at these new trials, so there's the triglyceride-lowering therapy to reduce major atherosclerotic cardiovascular events after statin treatment. I just told you about the reduced and strength. Very surprisingly, one gave a 25% ASCVD risk reduction, the other one, no effect. So we are really eagerly awaiting the prominent trial that uses pemafibrate. It's a selective proximate proliferator alpha. So it's a modern fibrate, you could say, and it's tested in diabetics only with high triglycerides and low HDL cholesterol. It is fully recruited and results will come in a few years' time. The various guidelines, big lipid guidelines, are not focusing on the diabetes guidelines, specifically the UK NICE, the Canadian, the European ESCES, and the American ACCHA. When you look at people with diabetes show down here, then all guidelines say, let's get LDL down. There's some percentage or some values to come down to. But then they say, secondly, please make sure that non-HDL cholesterol is coming down and that ApoB is coming down in the Canadian and European guidelines. And this, of course, is a reflection of triglyceride lipoprotein. This is particularly relevant in diabetic patients. So my final slide is like one of my first slides, about HDL. I think forget about it when you think about preventing cardiovascular disease. There's no evidence today that HDL cholesterol can take cholesterol away from the arterial wall. So it's mysterious what it does, but focus on these three. LDL causes atherosclerosis. Therefore, in a diabetic patient, get LDL down as much as possible. And then secondly, the remnants or the triglyceride lipoproteins, particularly because they might cause inflamed plaques, they are the next target for lipids to do. And then Lp(a), as this can cause maybe indirectly thrombosis, but it's not a major thing in diabetics particularly, we'll have to wait to new treatment. So focus on LDL, and secondly, get remnants down and forget about HDL. Thank you so much for your attention.
Thank you very much, Professor Nordesgaard. So our final speaker is Dr. James Underberg. Dr. James Underberg is going to talk to us about treat to target. Is that better? Percentage reduction versus high dose statin. Is there a best practice? Professor Underberg is a clinical assistant professor of medicine in the Division of General Internal Medicine at NYU and is a member of the executive committee of the Division of General Internal Medicine. He is a director of the Bellevue Hospital Lipid Clinic, and his clinical focus is preventive cardiovascular medicine. So now over to Professor James Underberg.
Hello, my name is Dr. James Underberg. I am a clinical assistant professor of medicine at the NYU School of Medicine and the NYU Langone Center for the Prevention of Cardiovascular Disease. I'm also the director of the Bellevue Hospital Lipid Clinic in New York City, past president of the National Lipid Association, and current president of the American Board of Clinical Lipidology. I'd like to thank the meeting organizers for the kind invitation to speak to you today. The title of this is Treat to Target, Better Percentage Reduction versus High Dose Statin. Is there a best practice? I'm going to take this and manipulate it a little bit just so that we have a nice direction on where we're going. And hopefully we can bring up some interesting points worth discussing today. These are my disclosures. And I want to start by getting facts straight. I want to talk about a couple of terms that I think often get bandied about, often confused or used inappropriately. Every now and then I pick up a journal article and I see something in a title that actually has gone through peer review, and it says treat to target. Treat to target makes absolutely no sense. Why? Because a target is what we aim at. A target is LDL cholesterol. It's hemoglobin A1C, it's systolic blood pressure. It's what we're aiming to treat. The goal is what we treat the target to. We treat to a goal, an LDL cholesterol less than 70, systolic blood pressure less than 130, etc. And so the phrase treat to target makes absolutely no sense. We treat targets to goals, but then what has come into play more recently is the concept of threshold. And so I've listed a definition for threshold here on the top, the magnitude or intensity that must be exceeded for a certain reaction, phenomenon, result, or condition to occur or be manifested. And so thresholds are where you intervene in the case of lipid management with lipid-altering therapy. And the intervention is what is deemed to be the therapeutic intervention itself, not the number per se that you are trying to achieve. And why is this important? Well, if we think about goals and say we're trying to treat to a goal less than 70 milligrams per deciliter. If someone's LDL cholesterol is 72, I don't think anyone believes that taking their LDL from 72 to 69 and magically crossing that number 70 has done anything with therapeutic value for the particular patient. And so I thought it was important to spend a little time on these concepts because they apply directly to some of the things I was asked to speak to. Now, when it comes to the role of LDL cholesterol in cardiovascular risk, there are really 4 lines of evidence that support causality for LDL cholesterol and ASCVD risk. We start with the idea of experimental or animal data. And we know that if you knock out ApoE, and mostly in rodents, and you feed them a high-fat diet, you can see the rapid progression of atherosclerosis, and you can mark that anatomically. And if you reverse the process, if you actually lower LDL cholesterol, you can make atherosclerosis go away. Observational data, mostly epidemiologic studies, reminds us that there is a linear relationship between LDL cholesterol and risk of cardiovascular events, in this case, myocardial infarction. As LDL goes up, risk goes up. As LDL goes down, risk goes down. We also have interventional data. Listed here primarily are statins, ezetimibe, and PCSK9 inhibitors. We even have data with bile acid sequestrants, all showing this relationship, that if you lower someone's LDL cholesterol safely, you can reduce their risk of cardiovascular events. And then finally, probably the most compelling and newer data is that of human genetics. Both GWAS and Mendelian randomization studies remind us that patients born with mutations that either raise or lower LDL cholesterol have associated increased or decreased risk of atherosclerotic cardiovascular disease. And what's so compelling about this human genetic data is it shows the importance of a risk factor's impact over time, right, over the course of the lifetime. And this is significantly demonstrated here, where we have 3 different curves. The top curve is the Mendelian randomization data, and this is the steepest curve. Why is it the steepest curve? Because it's associated with the longest duration of impact. And in this case, patients who have mutations that increase LDL cholesterol, or patients that have mutations that decrease LDL cholesterol, are associated with increased or decreased levels of LDL and subsequent appropriate interactions with regards to the impact on cardiovascular disease risk. In the middle are the prospective cohort studies, observational data, and then the curve that is the least steep is the interventional data. Why? Because these are the shortest duration of observation, right? Clinical trials, generally 5 years. Now some of the newer PCSK9 data is 2.5 to 4 years. And so less exposure or reduction of exposure to the important risk factor here, which is LDL cholesterol. And so subsequently a less steep curve. Now, we have really great data reminding us that lower is better when it comes to LDL cholesterol. This is a meta-analysis of statin trials, but I could show it to you with other data too, just reminding us that there is a trend towards reduction in risk as we continue to go down the LDL cholesterol curve. What this does not tell us, though, is that small changes along this line do not necessarily impact reductions in risk. The trend to lower is better, but we don't necessarily know that going from an LDL of 56 to less than 50 is actually going to move the bar. And in fact, it probably won't, right? Because there are significant determinants of risk when it comes to change in LDL cholesterol levels. And you can see the same data here: major coronary events, major cardiovascular events, all seem to go down with reductions in LDL cholesterol. So why are we talking about LDL cholesterol at all? It remains obviously a significant risk factor. Here we're looking at myocardial infarction in young adults, and one of the most important risk factors, hypertension, lipids, and smoking. And so again, these temporal trends don't seem to be changing much over time, and I think it's important that we address them. This is probably one of the most important graphics I will show you during this session, and I think it's important to understand this concept, which is that reduction in events occurs with reduction in LDL cholesterol, seen here and here, when we look at both major vascular events and vascular deaths avoided. And this is data from the cholesterol treatment trial. It's Collaborator. It's a little old now. It's from 2012, but I think it's highly impactful. But the reduction in events is even stronger when patients are treated who have higher risk for cardiovascular disease, right? That the benefit of a lipid intervention is impactful when you change LDL a lot or you intervene in a higher risk patient. So the benefit relates to the risk of the patient, how high the LDL cholesterol is, and how much you change LDL. And de facto, if LDL cholesterol is high, the same percent intervention will lower it from an absolute perspective more. So that's why patients with higher LDLs benefit from the same intervention, because the absolute change in LDL is greater, patients with greater risk benefit. And so because of that, risk assessment is such an important part of the way we think about cholesterol lowering. And so if we look at the AHA-ACC 2018 guidelines here in the US, there's an important component to assess risk prior to prescribing medication or thinking about who would benefit from lipid-lowering medicine, whether it's high-intensity statin, moderate-intensity statin, and what are the therapeutic cutoffs for when we want to intensify therapy. And so assessing 10-year and lifetime risk is important. Coronary calcium score is important. Risk-enhancing factors are important. And there are some risk assessment tools that focus only on primary prevention. And so here is the overall algorithm for the primary prevention guideline. And what we see here is, first, in younger patients, the importance of assessing lifetime risk. And that's what I was talking about when I said primary prevention tools. The lifetime risk calculator is very important in younger patients because their 10-year risk is going to be low no matter what risk factors you give them otherwise. And so looking at lifetime risk is key. In patients who are older, between 40 and 75, the key next step is to focus on 10-year risk. You can either use the pooled cohort equation, Reynolds risk score. In Europe, I know you use SCORE. But again, the key components of this are to focus on the patients who benefit from further risk discrimination. The lower risk patients, they don't need treatment with pharmacologic agents. They need to have lifestyle emphasized as a risk-reducing strategy. And the very high-risk patients, those with 10-year risk greater than or equal to 20%, we go right to high-intensity statin therapy with these patients. And the ASCVD risk calculator is available on phones. You can download it. This is the desktop version. You estimate the patient's 10-year risk. You forecast the potential impact of different interventions, assess ASCVD risk at follow-up visits, and use the information to help with clinician-patient discussions on risk-lowering interventions. This is the ASCVD lifetime risk estimator, and you can see the URL for it. You have this in the slides that I'm making available to everyone. And I would tell you to use this in younger patients. It's very, very important, an important tool. But in these borderline and, more importantly, the intermediate risk patients, 7.5 to 20%, again, sometimes people are on the fence about whether or not to initiate statin therapy. And that's where I think we have some nice additional tools now. And coronary artery calcium screening is one of those tools. And I would encourage people to consider using it in these borderline and intermediate risk patients. It really helps either up or down risk a patient. This is a nice graphic looking at the potential role of coronary artery calcium screening. And I point to these two middle categories, the 5 to 7.5% or the 7.5 to 20% risk. These are the ones where generally statins may be recommended. If the calcium score is greater than 0, we definitely would recommend a statin in the higher risk group, but we would certainly consider it in the moderate risk group. If the score was 0, then we would not recommend it in either group. Whereas in the low risk and the high risk groups, using a coronary calcium score will not actually change your therapeutic options. And so it's really only recommended in this group. But in addition, we have other tools that we can look at to further refine risk assessment in the primary prevention cohort. These are called the ASCVD risk enhancers. Many of these are things that we would do anyway as part of a good history and physical. Family history of premature ASCVD, persistently elevated LDL greater than 160 milligrams per deciliter, patients with chronic kidney disease, metabolic syndrome, conditions specific to women such as preeclampsia and premature menopause, inflammatory diseases, rheumatoid arthritis, psoriasis, etc., and South Asian ancestry. And then we have lipid biomarkers. These are things that we commonly measure, such as triglycerides. We get that with every lipid panel. If it's greater than 175, this is a significant risk factor. It up scores a patient with regards to their risk and might tip the balance in favor of treatment. And in fact, the guidelines specifically focus on the risk associated with high triglycerides. and the importance of LDL lowering in patients with triglyceride levels between 150 and 499. And then finally, there are some additional biomarkers that we can check if we'd like to, but you don't have to do this in everyone. High sensitivity C-reactive protein, lipoprotein A, ApoB, or ankle brachial index. And all of these can help us further assess risk. These next two slides just pull out these risk enhancing factors in an easier to read graphic for you. So I've already gone through it. It's here for your review in the slide set, and I encourage you to familiarize yourself with these if you don't already know them. So who needs primary prevention? Well, patients with severe hypercholesterolemia. These are patients with inherited disorders of LDL cholesterol metabolism, for familial hypercholesterolemia, and they're automatically put into the high-risk category. Do not risk score them, because if they're young, they'll actually appear at the low end of the risk score. Patients with diabetes over the age of 40 should all be on moderate intensity statin. And then the primary prevention cohort that we've discussed. So in these patients with primary severe hypercholesterolemia, LDL levels greater than 190 milligrams per deciliter or 4.9 millimoles per liter, they're diagnosed clinically generally, but you can also diagnose them with either an app on iPhone or Androids, or these scoring systems such as the Dutch Lipid Clinic Network, Simon Groom, MedPed, or the American Heart Association criteria. They can be diagnosed genetically. And even in patients where you can't make a diagnosis of familial hypercholesterolemia, if their LDL is greater than 220 milligrams per deciliter, they fall into the same high-risk category and should be treated as such with aggressive LDL lowering and high-intensity statins. And while this is not a talk about familial hypercholesterolemia, I couldn't resist one very important slide that I think really drives home this concept of risk and cholesterol. And these are patients, all comers, with LDL cholesterol levels in increasing categories. And you see on the right, patients with LDLs greater than 190 and greater than 220. And in the light blue, they're patients with no known mutation. And you can see that their risk is 5 to almost 8 times greater. But if they have a mutation, their risk is 17 to 25 times greater. So even if you risk adjust that based on LDL cholesterol, you can see that the odds ratio is 6 in 22 for LDLs without and with an FH mutation. Why is that? I think it's because the presence of a mutation assures that the patient has had high cholesterol from the day they're born. And this speaks to the concept of cholesterol burden, or area under the curve. How long have we been exposed to high cholesterol for how long? Kind of like pack years with smoking. And I think this, again, speaks to the temporal relationship of the risk factor. The longer you're exposed to it, the greater the risk associated. So again, in primary patients, age 20 to 75, the key with these patients is to start them on high-intensity statins, add ezetimibe. We can even use bile acid sequestrants if we'd like, but I would tell you that more importantly now in these patients, a PCSK9 inhibitor is the next step after statins and ezetimibe in patients with familial hypercholesterolemia, or in that group of patients whose LDL cholesterol is greater than 220, you can't make a diagnosis of familial hypercholesterolemia. So what about diabetic patients? So diabetic patients obviously fall into a high-risk group, and all diabetics between the ages of 40 and 75 should be started on moderate intensity statin. That's just, I think, a reasonable, appropriate approach. However, not all diabetic patients are the same. We know this. And so within the diabetic cohort, there still is room for further risk assessment, because the higher the risk, the greater the benefit. Just like the higher the LDL, the greater the benefit in patients with familial hypercholesterolemia. I'm trying to kind of go over these concepts in the context of disease states that represent them. And that way, this all makes a lot more sense from an algorithmic perspective. So we are able to up score or up risk diabetic patients depending on particular risk factors. Again, most adults aged 40 to 75 years of age with diabetes are at intermediate risk or high risk based on the pooled cohort risk estimator. And again, moderate intensity statin is reasonable, but if they have additional risk factors, then using high intensity statin is certainly not unreasonable. And in some cases, adding on additional non-statin therapy, such as perhaps as ezetimibe, only because of the data that we have seen from the Improve It study, which I'll get to in a little bit. What are the diabetes-specific risk factors? Well, independent of other risk factors, long duration, greater than 10 years for type 2 diabetes, 20 years for type 1, albuminuria, retinopathy, neuropathy, or vascular disease as evidenced by a abnormal ankle brachial index. I also want to remind you how important it is to monitor response to drug therapy. There is a heterogeneity of response to statins, and you don't know how a patient will respond till you actually measure LDL and check. So, one of the topics in the original title was, is it just the intensity of statin therapy? And the answer is no, only because the intensity of statin therapy predicts what may happen, but you have to guarantee what happened. And the only way you can do that is to measure response, to measure LDL cholesterol and make sure the patient has actually achieved the desired LDL cholesterol reduction. Otherwise, it doesn't matter what you've prescribed for the patient. It doesn't matter what they're taking. If they don't get the expected response, then they won't get the appropriate reduction in risk. So when it comes to secondary prevention, just like primary prevention, statins remain the key cornerstone of lipid-altering therapy. We've listed here for you on the top the main primary prevention placebo-controlled trials, all demonstrating benefit with statins versus placebo. And then on the bottom, the 4 pivotal placebo-controlled secondary prevention trials, 4S Care and Lipid, done with simvastatin and pravastatin, reminding us that landmark statin clinical trials show that LDL cholesterol is strongly associated with risk of ASCVD. And the cholesterol treatment trialist collaborative meta-analysis showed that for every 1 millimole, or about 39 milligrams per deciliter reduction in LDL cholesterol, there's a 20 to 25% reduction in major CV endpoints. Statins are clearly the mainstay of therapy, yet despite statin therapy in all of these trials, there's a significant amount of residual risk that continues to drive events in patients that we would consider reasonably treated. And so where are we with non-statin therapy in this concept of additional LDL lowering? And trials such as Improve It, Fourier, and Odyssey Outcomes have really informed us of the role of adding safe LDL lowering agents to statins, ezetimibe, and PCSK9 inhibitors in the case of these trials. But it also reminds us that the benefit is not just associated with the intervention, it's associated with the degree of LDL lowering and the duration of therapy, right? So here in Improve It, you had to treat the patients for 7 years to get a small to moderate reduction in events. Why? Because the degree of LDL lowering was not that impactful. Fourier and Odyssey have greater reductions in event rates, 15% versus about 9 to 10%. And they only needed to treat these patients for 2.5 to 4 years. Why? Because the reduction in LDL was about 50%. So greater reduction, high-risk patients in all group, longer period of time for lesser reduction, shorter period of time for greater reduction. Here's the data from Improve It. I'm not going to belabor the point. Here's the data from Fourier. Primary and secondary endpoints show about a 15% and 20% reduction in LDL cholesterol, and Odyssey Outcomes, a 15% reduction in cardiovascular events. Again, you see the composite endpoint there. So again, the more robust the lipid lowering, the shorter duration of time needed to show cardiovascular benefit. The less robust the lipid lowering, the longer the duration. So what have we learned from subsequent analyses of these PCSK9 inhibitor trials? A variety of different things, but I would tell you probably the key points are that the higher the risk of the patients in the trial, the greater they benefit. And so there's some great evidence from sub-analyses in these trials that I think is well worth sharing. There are some other interesting things here that are not really pertinent to what I've been asked to talk about today. So given the time constraints of this session, I'm going to pass them over, but they're in that slide for you. But this is some great data from Improve It, looking at risk scoring within the overall population, showing us that the patients who have more risk indicators have greater benefit from the same intervention. The higher the risk, the greater the benefit. No surprise, we also see that in patients with additional risk factors in Fourier, such as diabetes, greater benefit versus those who don't have diabetes. And in Odyssey Outcomes, very similar. The diabetic patients had greater benefit from, in this case, alirocumab, than those with prediabetes or the overall cohort. When we look at type of myocardial infarction, this also seems to drive differences in benefit. Here, data from Fourier shows us that the patients with type 1 MIs seem to benefit to a greater extent than those with type 2 and type 4, the overall cohort. And patients with STEMI seem to do a little better than non-STEMI. Patients with more recent MIs do better than patients with distant MIs, greater risk reduction, because they're at higher risk. We know that. Someone who's had a recent MI is at a much greater risk of an event than someone who had a distant MI. And those with multiple MIs versus one, also greater risk, greater benefit. Multivessel disease versus no multivessel disease, no surprise there. Greater benefit with the patients given the same intervention. So once again, we've talked about the degree of LDL lowering, we've talked about the duration of therapy, and now I'm banging home this point that it's all about the risk. The greater the risk, the greater the benefit from the same intervention. And this is data in patients with and without peripheral artery disease. On the right are major limb events, right? Major adverse limb events, people forget. Significant reduction in things like amputation, patients treated with evolocumab versus placebo. But in the patients with PAD versus no PAD, you see this dramatic difference in absolute risk reduction, 3.5 versus 1.4%. Clearly, again, we know patients with peripheral artery disease are at extremely high risk of cardiovascular events. And so no surprise that they would benefit to a greater extent from the same degree of lipid lowering. Now, my colleagues across the pond, so to speak, in Europe, have understood this for a long time. Their method is slightly different than here in the US, where we have a threshold-based approach. And that's all based on the concept that if it's time to intervene, you need to make an intervention that will move the bar enough to change risk. Simply crossing over a value, a goal, may be a very small change, and that's not going to be beneficial, especially at the lower end of the curve, where risk starts to go down. You need to change LDL more, not less. It's actually the exact opposite of what most people think. And so again, here is a goal-based system based on increasing risk scores in patients. When you go from low to moderate to high to very high, the goals for these patients go from 116 to 100 to 70 to 55. And there is even a group down here at the bottom, very high-risk patients with a recurrent event within a 2-year period, where goals of less than 40 milligrams per deciliter are suggested. Now, what does this tell us? You know, I was asked to talk about, is it about the statin itself? Is it about the treatment to a goal? Is it about the change in LDL? I would tell you over and over again, it's about how much do you change LDL, and do you choose the right patients? The higher risk patients get the greater benefit. And so I would tell you that this approach, while different, ultimately has the same effect, which is by choosing extremely low goals in high risk patients, requires robust or large changes in LDL to get to that particular level. And so different pathways, but ultimately, I believe, all leading to the same endpoint. So in our 2018 blood cholesterol guidelines, in the secondary prevention cohort, we actually call out a group that we label as very high risk. And who are these very high risk patients? Well, they're patients with at least one of what they call major events, recent ACS, history of MI, ischemic stroke, or PAD. And actually, if you have 2 of these, you immediately fall into the high risk category. If you have only one of these 4 and then 2 of these additional, what we call high risk conditions, it turns out that that also puts you in a very high risk category. And recent data actually has suggested that if you actually look at patients with ASCVD, almost 90% of them will actually have either 2 of these or 1 of these and 2 of these. And so this makes up the majority of patients with ASCVD. Most of these patients are very high risk. And in our current guidelines, aggressive LDL lowering is warranted, not just with statins, but with statins, ezetimibe. And if the LDL is still above 100, then, if the LDL is still above 70, then adding a PCSK9 inhibitor. So this is a nice overview of how to think about risk and LDL lowering from a paper published by Jennifer Robinson back in 2016. And again, this speaks to this concept of risk and change in LDL. So in patients with very high LDL cholesterol levels here, right, they benefit from additional LDL lowering on top of statins with PCSK9 inhibitors. However, small changes in LDL, such as with ezetimibe alone, really won't move the bar. In patients at moderate risk, so lower risk patients, you have to use robust interventions, meaning a PCSK9 inhibitor, to make a difference. And in the high risk group, again, you have to move the bar with PCSK9 inhibitors. So some take-home points before I finish and wrap up. The risk of the patient determines the intensity of treatment. That's the answer to the question I was asked. The risk of the patient determines the intensity of treatment. The greater the risk, the greater reduction with the same degree of LDL lowering, hence the importance of risk assessment. The benefit of LDL lowering is related to the absolute change in LDL cholesterol. All things being equal, greater benefit the higher the risk. At the lower end of the LDL curve, paradoxically, we require greater percent changes in LDL cholesterol to reduce risk. And then in parentheses, I put to achieve meaningful absolute reduction in LDL cholesterol. Very small changes at the low end of the scale are a waste of time. Guidelines or recommendations based on the thresholds for intervention avoid the danger of small changes to cross over a goal. That crossing over effect is something that we just make up to make ourselves feel better. And so aggressive goal-based guidelines, such as the European guidelines, may also help achieve the same benefit by driving use of more aggressive therapeutic interventions at lower LDL cholesterol levels. And that is a typo, I apologize. It should be BY, not BUY. So I have come to the end of my time, and I thank you for your kind attention. And again, I apologize for not being present in a live setting, but I had a prior commitment that took me out of New York at the time this would be taking place. And so I have to substitute with this pre-recorded version instead. But again, I appreciate the kind intervention, and I'm very happy to be part of the program today. Thank you very much.
So it was a pleasure to hear Dr. Underberg. Unfortunately, he won't be able to be with us for the Q&A, as you just heard from the recording. So what we are going to do is that we are going to go ahead and have a few questions, and they are going to be based on the Q&A that came in from our participating colleagues. So let me just put the first question to Dr. Ira Goldberg. Dr. Goldberg, the question has to do with the variability in the glucose levels. So in terms of the glucotoxicity, would like to hear, what do you think about the persistent hyperglycemia versus the variability in terms of the glycemic control that you alluded to? So if you could just expand a little bit on it. Thanks.
Yeah, so this is more in the realm of a research question than a clinical question, really. So there's been reanalysis of things like the EDIC trial that, and people have argued that glucose variability is more highly associated with complication risk than average hemoglobin A1C. We also find that the hemoglobin A1C, for example, in prediabetes, sometimes not even prediabetes, sometimes even obese people who have hemoglobin A1Cs below 5.7, some of them will actually have very abnormal glucose tolerance tests. And then if you take those patients and you put a continuous glucose monitor on, which can also measure variability, it actually tracks with the glucose tolerance test. So what do you do as a clinician? Well, I agree with Dr. Nordesgaard that that the hemoglobin A1C is a better number to probably use to determine how you're going to treat people and how aggressively they're going to treat people. But we're more and more thinking that on some of the high-risk patients, we're going to give them a glucose tolerance test and see how high they go. One of my faculty is especially interested actually in the 1 hour value, which actually turns out to track even better than the 2 hour value with glucose variability.
is there a particular subset of patients that you would recommend this for? I mean, what would be the clinical features or markers that you would say that these people are the ones who would benefit from that?
Yeah, so the people that we worry about are the people who have, where the hemoglobin A1C does not set off an alarm, but they're overweight. They're the patients that you heard about from Dr. Nordesgaard who tend to have low HDL and high triglycerides. So the called metabolic syndrome patients. So it's pretty clear metabolic syndrome patients, even without elevated hemoglobin A1C, are at increased risk. And we have a sense that numbers of them will have abnormal glucose tolerance and abnormal glucose variability. So we think that they should be treated more aggressively, than you would treat somebody who apparently doesn't have diabetes. So they're obese, often low HDL, high triglycerides, sometimes with hypertension.
Thank you. I'll move on to Professor Nordesgaard. There are a few questions which are, again, very practical in nature. And one of them has to do with a lady who is pregnant. When would you discontinue the statin? We can't hear you. You have to unmute, sir.
Yeah. I would, in my point of view, I think most women, I would just advise them not to take statin during the entire period of being pregnancy. If you look at what's important for atherosclerotic cardiovascular disease is the lifetime exposure to high LDL cholesterol. So even when you have somebody with familial hypercholesterolemia, if you have treated them for some years and the woman wants to be pregnant, I would advise to stop the statin, and then as soon as maybe she finishes giving breastfeeding the child or something, start statin again. So it's a lifetime exposure that matters.
Understood. What about the use of statins in prediabetes? You had mentioned something about it in your lecture, but is there sort of some clinical idea that you can give us as to, okay, here the risk is worth taking?
But yeah. I think what Goldberg said, I fully understand the argument that there's this small tilt in more coming from prediabetes to diabetes, but I must say I'm very much in favor of the really hardcore evidence-based medicine, and that I'm not a cardiologist anymore. I used to be, but statins reduces cardiovascular disease and it makes people live longer. So I'm not too worried about this small increase in switching from prediabetes to diabetes. So I would just use high dose or high intensity statins as much as possible in diabetic patients.
So here's the counter argument to that. The counter argument is that something like 10 milligrams of rosuvastatin plus ezetimibe will cause more LDL lowering than raising the rosuvastatin dose fourfold. So, and that's there. So if you believe that the risk correlates with LDL reduction, you get more LDL reduction going with a different approach without having a risk of pushing somebody with prediabetes into somebody with diabetes. And since I'm an endocrinologist, not a cardiologist, I have to treat the diabetes.
No, but Dr. Goldberg, I don't disagree with you. I think if it's a patient with solely LDL elevation, I think your suggestion is perfectly fine, and in many cases be better. It's this is if you have a patient that understands they have to take 2 different pills and the complication, whatever that comes into that. So if it works, that's perfectly fine. Low dose statin and ezetimibe, I don't mind that at all. But I think for many patients, it's just taking 2 pills for prevention may become more complicated than taking a single one. So therefore, I think they're better off just getting a high dose statin. And I think particularly if they also have triglycerides elevation, which is what I talked about, because then ezetimibe is not very good.
Yeah. So we are getting these combo pills now, so that would take away the need for 2 different pills.
I mean,
Yeah,
I
go
think
ahead.
the other approach is to use the high dose statin and say, look, if this particular patient now, moves from pre-diabetes into diabetes, then we're going to drop back and, have another approach.
Yeah, that would be fine with me. So as I said, I don't mind the argument. I just know evidence-based medicine shows that high intensity statin, it works. That's for sure.
Agreed. So, Dr. Nordesgaard, a couple of other practical things that people are asking about is that you mentioned that there is now a move towards not, looking for fasting lipid profiles. So the normal testing that we do, that applies. I mean, the same values and everything will work even if you do the non-fasting testing, right?
Yeah, sure. I mean, so I've been in chairing some European consensus statements, going into these discussions a lot. In the beginning, of course, many lipidologists say, oh, we can't get away with this fasting things. And so we ended up having two different cut points for fasting triglycerides and non-fasting, being just 0.3 millimoles per liter higher for the non-fasting. But if you ask my honest opinion, I don't think it matters. I think you're much better off just measuring non-fasting. You get a better picture of what triglyceride levels the patient has on a 24-hour circle, and just use the same cut points. That's what we do. I work in clinical biochemistry. I have the biggest laboratory in Copenhagen. That's what we do. We use exactly the same cut points for fasting and non-fasting.
Sure. What about hypertriglyceridemia in pregnancy? How do you manage that?
Yeah, but that's a special case because estrogen, high levels of estrogen, when in some women lead to very high triglycerides and then the chylomicronemia syndrome. So if you have a woman that have very high triglycerides, particularly in the third trimester, and at risk of chylomicronemia and therefore acute pancreatitis, and I have personally followed a number of these patients, and I've even been involved in some that died during this hypertriglyceridemia. So basically, I think all women in third trimester should have triglyceride checked. And if it is very high, I would not give a drug. What you can do is you can put them on a no-fat diet, or it's a really zero-fat diet, less than 30 grams per day, and you need a clinical dietitian to counsel the patient, because all you need to do is to have the woman maybe bring triglycerides down below 25 millimoles, or as low as possible, until she gives birth. Because after that, estrogen drops, and then triglyceride drops, and the problem is gone. The only other option you can do at this stage is some countries offer apheresis for women with such high chylomicronemia, and that works fine. So if that's available, that's the other option. But otherwise, zero fat, and there's no worry. The child would not lack fat because the child can just take some of the fat from the blood of the mother. So there's plenty of fat for the child.
Okay, understood. Dr. Goldberg, what about myalgias? In your practice, how do you deal with that, particularly with high-dose statins?
Yeah, so that's a real problem. And in most US lipid clinics, about 50% of the patients, probably true in Denmark too, about 50% of the patients referred to a lipid clinic now are so-called statin myalgias. There's been enough studies and crossovers that probably it looks like from the clinical data, about 85% of those patients cannot really tell the difference between statin and placebo. But that means 15% can, and there are a lot of those. So, whether you think your patient really has statin myalgias or you think they're going to have statin myalgias on a placebo doesn't really matter, because the patient's not going to take the drug, or you're going to convince them to do it. So people switch around one statin after another. I did the same thing. My favorite is to have them take something like 10 milligrams of rosuvastatin Monday, Wednesday, and Friday. And then I tell them that on Tuesday, Thursday, and the weekend, their muscle sees no statin, and that 90% of the people do perfectly fine on the every other day dose. I have no evidence that that's true, by the way, but I tell them that anyway. And then sometimes patients just don't, just won't tolerate a statin. And then you know, the backup is ezetimibe, the new bempedoic acid, and PCSK9. And if they have cardiovascular disease, or in the US, high calcium levels, you can get the PCSK9 for people who are complaining of statin intolerance. I should mention the biology of that, even after 3 decades, is still unclear.
Very quickly, do you follow like LFTs, CPK, anything for these patients?
No, in fact, I don't. I'll get LFTs on a baseline because I want to make sure that my hypercholesterolemic patient has normal liver functions. I will only get a CK level if I think I'm going to have a patient who's going to complain to me, and I have a sense of that, so I could get a baseline and then show them it hasn't changed, and then I'll get a CK. So I don't usually get CKs. I also warn them because occasionally you do have a patient who gets rhabdomyolysis. And so my usual warning is if you wake up in the morning and you feel like you're achy, you don't have rhabdomyolysis, don't call me. If you can't get out of bed because you feel like you have the worst flu of your life, then I want to know about it. And you need to, you could have rhabdomyolysis.
We cannot hear you.
Yeah.
There you go.
Yeah.
Better now?
Mhm.
Yeah.
People with already pre-existing liver disease, fatty liver, elevated LFTs, things like that, how do you manage them?
Dr. Goldberg, maybe you. Yeah.
Yeah, what do I do with them? Well, so they're usually overweight. So the best treatment is something like a GLP-1, actually, because it'll make them lose weight and it helps the fatty liver. The data on statins is, if anything, the liver functions get better on statins. So, and the people with NAFLD, some of them will go on to liver failure, but way more of them will go on to have cardiovascular disease.
Excellent. So with that, we will conclude the Q&A part. I would again thank you both Dr. Goldberg and Dr. Nordesgaard for their active participation, and I hope that we were able to answer, if not all, but maybe most of the questions. So thank you very much, both of you. And with that, we are going to now move to the Amgen Symposium. And for that, I'm going to request my colleague, Dr. Tariq Fayad. Tariq is a consultant physician and endocrinologist at the Sheikh Khalifa Medical City, Abu Dhabi. He's an associate professor of medicine at the Granada Medical School, St. George's University School of Medicine. So with that, I'm going to hand over to Tariq.
Thank you very much, Hamid, for your kind introduction. And I'd like to thank the Diabetes Emergency Society for obviously giving me the opportunity to speak to you tonight, and also for our sponsor, Amgen, for their unconditional support. In the next 25 minutes or so, I'm really going to address the management of dyslipidemia in terms of futuristic view. So these are my disclosures, a disclaimer, and this is the outline of my presentation tonight. So I'll make the case really for more aggressive lipid-lowering therapy in specific circumstances, and I'm going to make the case there based on epidemiological evidence, interventional studies, and then I'll discuss. Okay, and I think some of the speakers alluded to that. Dr. Underberg, lower is better, but is earlier also better? And then I will refer to the guidelines, and then perhaps one of the probably important parts of this talk tonight is where do we stand now? because that reflects really into our practice before I conclude this presentation. And so epidemiological evidence, and ladies and gentlemen, this is, as you probably some of you came across this old data before, that's from the Mr. Fit study. And the Mr. Fit study is a study where they screened more than 250,000 men, and they observed them for about 12 years, looking at interaction of risk factors, including cholesterol, blood pressure, and cigarette smoking. And then they also looked at the role of diabetes. And what was evident when it came to the cardiovascular disease, death, the more the risk factors we have depicted in these brown columns, the greater is the risk of cardiovascular disease. However, in the setting of diabetes, this risk is really magnified by about 3 to 4 fold. And then they also looked at is it a graded risk? And the answer is yes, it was a graded risk. So the higher the cholesterol, the worse things are, and the lower the cholesterol up to a point of LDL below 100, there was, if you like, a lesser risk. So we learned at that time that cholesterol really is something that we ought really to control, and it's an important intervention to have. Now let's look at the interventional studies, and Dr. Goldberg again touched into this area concerning controlling, and this is the data really from Ray Kushik, and Ray really, what he did is he analyzed the data from 5 major studies in diabetes, and he looked at the CHD event reduction. So how many less events are we going to have by lowering the HbA1c by about 1% down, or total cholesterol by 1 millimole down, or systolic blood pressure by 4 millimeter of mercury down? When we treat 200 patients with type 2, so the data is in type 2 diabetes, for about 5 years. And what was clear is that by getting the A1C down by 1% approximately, we will have 3 less events. Getting the cholesterol down by 1 millimole, we're talking about 8 less events, and the blood pressure by 12 less events over the course of the 5 years. Again, underscoring the importance of really, when we deal with diabetes, to have comprehensive management of all the risk factors. And this is a similar really data from a different study. Again, they're looking at the first cardiovascular disease hospitalization and the control of these risk factors. So if you look at the second column from the left, it's controlling HbA1c, and then if you go next to it, to the right of that column, controlling blood pressure and lipids. So it was obvious that getting the lipids and the blood pressure under control pays dividend. And then obviously the holy grail is to control all the risk factors, because that's what will yield the maximum benefit to our patients. And then this is a pooled data again, which is again showing us that driving the LDL or non-HDL down to a level of less than 50 for LDL or less than 75 for non-HDL, again, will drive the major cardiovascular disease events down. And I think for the practicing clinician, if your target's non-HDL, and Dr. Burke talked about non-fasting, which is extremely important, not only important, but helpful for the patient. So we don't send them and say, come back next day for a fasting, because they will never come back next day. We just do the fasting, and we can do the non-fasting, and we can check the non-HDL as, again, an important target. And with that, we can just modify the number. So for the LDL goal, we just add 30 milligram per deciliter, and that will give us the non-HDL goal. Okay, so we knew that getting the LDL to that level was important. The evidence advanced further. So now using ezetimibe on top of statin. That study, they improved it, brought the LDL down to a 53 milligram per deciliter. Was that associated with benefit? And the answer is yes. So the primary endpoint in the improve it was achieved, and there was significant reduction in event rates. Again, if you look at myocardial infarction, significant reduction, ischemic stroke, significant reduction. And then if we look at was there any difference in the response between people with and without diabetes? We can see that people with diabetes did much better when it came to the use and adding of ezetimibe, for a good reason, and that's because of the expression of the Niemann-Pick is greater in the brush border of the intestine in people with diabetes. So we knew that diabetes responded very well by adding ezetimibe in this trial. And the question that was then brought forward, does more stringent LDL lowering translates into less events? Because we still have residual risk, as Dr. Underberg alluded to. So this brought us to the PCSK9 inhibitors, and this is really again another important really discovery thanks to the science, where and PCSK protein is produced by hepatocyte, and this protein, the PCSK9, chaperone the LDL receptor into the cell, but once it's chaperoned to the cell, it's chaperoned to its destruction, its death. So it is a bad companion when it accompanies the receptor into the cell. So there'd be less LDL receptor that resurface again to take LDL and to lower it. So once we target that nasty protein by this monoclonal antibody, evolocumab, then there'll be more LDL receptor that will recirculate back to the surface and will lower the LDL. So what was the impact of treatment with this PCSK9 inhibitor? Well, it did what it's supposed to do. So a gratifying LDL lowering by about 60%, with an absolute reduction LDL of about 56 milligram per deciliter. Was that associated? And by the way, the median LDL now is 30 milligram per deciliter. So really we're going into a new territory of low LDL values. Was that associated with a benefit? And the answer is yes, it was associated. So the primary endpoint was achieved. There was significant reduction in the composite of cardiovascular death, MI, stroke, hospitalization because of unstable angina. We are talking in the diabetes forum, what happened to people with diabetes in this trial. So let's look at the data. So to the left is people with diabetes, to the right is people without diabetes. So you can see that there was a significant relative risk reduction in diabetes of 17%. So diabetes responded very well indeed. And again, if we look at the numbers needed to treat, 37, and people without diabetes, the number needs to treat is 62. So why is that? Dr. Underberg told us clearly why is that, and that's because diabetes, and when you give the treatment to a very high risk group, the numbers needed to treat is less. This is the simple answer to that. So people with diabetes responded very well to the treatment indeed. The next question is lower is better, but is earlier intervention also better? And let's look into the randomized trial of Nature. Again, Dr. Underberg spoke about it, I must say. So when we do interventional trials, By getting the LDL cholesterol down by 1 millimole, we will observe approximately 22% relative risk reduction in events. Now let's look at the genetic polymorphism, people who are born with a very low LDL. So to the y-axis, we have the log, we have the log scale, and the x-axis, please notice that there's difference really in the units there. So to the right, in the interventional studies, we're talking about millimole per liter up to 2. To the left, we are talking about really milligram per deciliter up to 18. So what we see evidently in people who are born with a low LDL, and so these are different genetic polymorphism. If you're born with even a lower LDL compared to a bit of a higher LDL, you reduce your risk by 55% or so. What this means when it comes to interpretation of this clinically? This is what we call the LDL burden. So if we have low LDL burden right from birth compared to somebody with higher LDL burden right from birth, the lower one will have a much greater reduction in events relatively of about 55% compared to somebody in interventional trials who were already exposed to higher burden for many, many years. What will this tell us? This is telling us indirectly that we need to implement our interventional measures as early as possible to have impact on treatment. Dr. Underberg showed you this slide, and again, the proportion of reduction. And people who have this genetic polymorphism, the curve is steeper, a greater reduction with once you reduce your LDL. Observational studies which take longer, and these are the interventional studies, short period of time in patients already exposed to high LDL burden for many years. That reduction in the risk is only modest. And this is again data which is addressing the LDL burden. And what you see in the, and this red line, the horizontal line, represent LDL burden of approximately 300 milligram per deciliter for 20 years. So you are going to reach that when you have homozygous familial dyslipidemia much earlier. You reach it with a heterozygous somewhat later. But if you intervene, and this is an example when you intervene with low statin, but you intervene early enough, you are going to delay the time by which you're going to develop your CHD. And you're delayed actually much better than if you give your statin later, maybe 10 years later, and use high intensity statin. The message was quite clear. Start your treatment in a timely fashion as early as possible and don't delay it if you want to have maximum impact on a reduction in event rates. And this is the data from the Heart of Protection study. And again, it's telling us, and this is the extension to the study beyond 5 years. People who responded to statin here, they continue to have the benefit. Although in the next 5 years, here in the shaded green area, everybody took a statin and there was no difference in the treatment. However, those who took statin for the first 5 years continue to have a greater absolute reduction in event rates. Again, underscoring the importance of timely introduction of treatment. And the authors concluded by these two recommendations: prompt initiation and long-term continuation of the treatment. What do the guidelines say to us? The guidelines, and this is really 2019 guidelines in diabetes, split patients into 3 categories. So the very high risk group, Among them, people who already have an event or end organ, target organ damage, like chronic kidney disease, like left ventricular hypertrophy, retinopathy, proteinuria. 3 or more risk factors. Duration is a very important factor, very important determinant of the risk. And the recommendation, people with type 1, and here what we are seeing is longer than 20 years. We're seeing many patients with type 1 diabetes coming to us in the clinic, adult clinics, spend with diabetes, type 1 diabetes, 25 years. And when they come to us in the clinic, they are not on any intervention whatsoever when it comes to lipids. Now, the guidelines are very clear in the recommendation. These are very high risk patients. The lifetime risk is very high, and we need to intervene. And then we have the high risk patients, and these are and belong to this group are patients with a duration. Again, the duration of diabetes is extremely important. 10 or more years plus any additional vascular risk factors. And then we have all the remainder of people with diabetes who belong to the moderate risk group. So, very high risk group. What are the recommendations from the society? The recommendation, the very high risk group, is to get the LDL to less than 1.4. But there's something else which is very important. We know that diabetic dyslipidemia, there's a atherogenic lipoprotein phenotype. So what we have is a modest elevation of LDL in most of the patients. There's a rise in triglyceride, there's lowering of HDL, but the LDL is not impressively elevated. We see many patients with LDL of 2.5, let's say. And again, Dr. Underberg alluded to this. Are we going, if we give them just a low intensity statin, it's very easy to get them to less than 1.8. But the key thing is not only getting them to the 1.4, but getting them by greater than 50% reduction from their baseline, because that's what's going to alter their outcome, a meaningful reduction in LDL from baseline. So it's complete waste of time to go from 1.9 to 1.6. That's only 0.3 millimole reduction. So it's very important to achieve that 50%. So if I have somebody with a baseline of 2.2, I need to get them to 1.1. That is what the maths is about. And the same thing, if I have somebody with high risk, then I need to get them to the goal of 1.8, but also to achieve that reduction in the LDL of 50%. So that's the key recommendation in these guidelines. What will achieve that? Moderate intensity statin is not going to get you to goal, because it will get down your LDL by 30%. That's the list of the treatment, whether it's a monotherapy or combinations with ezetimibe or PCSK9 inhibitors, or the combination of 3, which is going to get you to goal in the high risk and the very high risk patients. This is the data from the PROVE-IT-TIMI in patients who are taking high intensity statin. And we can see that a third of these patients did not reach the goal even with a TORVA 80. But if we are now going to implement the new guidelines, and the new guidelines are recommending less than 1.4 plus 50% reduction with a TORVA 80 in PROVE-IT-TIMI with a TORVA 80, 2/3 of the patients are still above 1.4 millimole per liter. Again, making the case that yes, high-intensity statin is very important, but it may not be enough in many patients, more so with the high risk and the very high risk patients. Where do we stand? And probably this is the most important part of the talk. And we analyzed our data from Sheikh Khalifa Medical City in primary prevention. And when we look at the score, 10-year atherosclerotic cardiovascular event score of 7.5% or greater. These patients, the recommendation is high intensity statin. As a matter of fact, only 27% of our patients were taking high intensity, implying that we have 73% in whom we need to revisit our treatment in order to get them to the goal and to the recommendation of the guidelines. We went on to look at the very high-risk patients' secondary prevention. All these patients should achieve LDL reduction of by more than 50%. To get that, you need a minimum of high-intensity statin. More than half of our patients were not taking high-intensity statin, implying that we need to reappraise our practice in more than half of our patients by up-titrating the statin as well as adding additional therapies to get our patients to goal. Let's look at the Da Vinci analysis from Europe. Again, an important analysis which came recently, looking at the adherence to the 2016 European Atherosclerosis Society guidelines and what we need to do if we are going to reach the goals recommended in 2019, which I just shared with you earlier. And that analysis, there were about half of the patients were primary prevention, another half were secondary prevention. If you want to know exactly, in that an observational study, approximately 2/3 belong to the very high risk group. But this is the pattern of the prescribing. Moderate intensity statin was the leading therapy, although 2/3 are very high risk patients who will need a minimum of 50% reduction in LDL. You cannot achieve it with moderate intensity statin. And even as our previous speakers are saying, that you cannot guarantee that you're going to see a response with high intensity because we have hyperresponders, we have other factors, we have the patient who cannot tolerate the treatment, you have many conditions whereby even the baseline LDL, which can be high as well. High intensity, only 1/3. Interestingly, combination therapy was only used by 9% of the prescribers. And if you want to know the difference between the behavior of the primary care physician and secondary care, they were very similar. And then intensive treatment, surprisingly, only 1% used that tool. So overall, if you want to look at the recommendation of the 2016, 55% reached the recommended goal based on the 2016. If you want to apply the 2019 European Society of Atherosclerosis and European Society of Cardiology, only 1/3 reached the goal. Now, let's look at the very high-risk patients. How many were prescribed recommended statin treatment? As a matter of fact, 45% were given only moderate intensity statin. 37% in green in this pie chart were given high intensity. Combination treatment, only 9%. Although with the combination treatment, if you look at this dotted arrow, even with the combination treatment, you're going to see only your 21% of your patients, 1 in 5, will reach the goal recommended by the 2019 guidelines. When you use your most robust treatment, PCSK9 inhibitor plus other treatments, including statin, you're talking about 60% of your patients reaching the goal. So it's really a wake-up call. And again, the guidelines, and for the sake of time, I'll go there. If you look at the patients who are going to reach your goal based on the 2019 guidelines at the moment, with the practice that's been done, less than 1 in 5 of the patients are reaching the goal, in spite of the modalities of treatments at our disposal. So, ladies and gentlemen, remember the therapies that we have under our disposal and how much is the magnitude of LDL reduction that you are going to achieve with the therapy, because that really is going to guide you into how much you need for a patient who's sitting in front of you. So, conclusions. Cardiovascular disease remains the leading cause of morbidity and mortality. The evidence, we know it very well. The evidence for reducing cardiovascular disease by substantial lowering of LDL cholesterol is what? Is compelling, strong, and convincing. Dyslipidemia treatment goals have recently been reduced. Newer and lower treatment goals will likely necessitate combination lipid lowering treatment, because it's unlikely that we are going to achieve it with a monotherapy intervention. We have an array of established, new, as well as emerging agents, which can bring the LDL cholesterol to guideline recommended goals. Yet, reaching these goals remains elusive. And why is it elusive then? Although we have an array of very effective therapies. Our inability to drive patients to therapeutic goals raises serious questions concerning a number of things, concerning our current approach towards knowledge dissemination. How are we educating ourselves and our colleagues about evidence interpretation? Because the data has shown that clinicians do vary in their interpretation of the evidence. And they would say, yes, the evidence is there, LDL of less than, lower LDL is important, but I don't think it is suitable for my patient. I'm not sure. And we saw the studies which show that very clearly. Serious questions about, if we understand the guidelines, about implementation. We may understand it, but we don't implement. And then serious questions about how are we engaging patients in the decision making and ensure that our patients are empowered on not only understanding the value of the treatment, but how for this asymptomatic condition about their adherence and persistence with the therapy in the long term. Thank you for your listening and for your attention.
Thank you, Tarek. As usual, it was very, very entertaining. So I think the take-home messages are that for sure, earlier intervention is better. And also the fact that we are still far behind where we should be in terms of active management. I just have a couple of quick questions for you before we conclude for the night. And the first one has to do with statin therapy in type 1 diabetes. What are your general clinical recommendations there? We saw the timelines that if it is greater than 20, then years of type 1, that becomes high risk. But generally, what do you do in clinical practice?
That's a group of individuals who if we look at their lifetime risk, it's extremely high. They develop diabetes at a very early age compared to type 2 generally, and we tend to have more of a glucocentric approach to those patients, and we tend to dismiss the management of dyslipidemia in these patients. And I'm very pleased that the recent guidelines have brought it to the forefront, because a patient with a long duration diabetes, and we know it really even from the studies which addressing the question about is diabetes a risk, cardiovascular risk equivalent, and those studies are showing very well that if you have a diabetes duration of more than 10 years, then it does become a cardiovascular risk equivalent. So yes, and a patient with type 1 diabetes of a long duration of more than 20 years, I will use the statin treatment. Obviously, if it's in a woman in the reproductive age group, and that I think that came in the last question round, I will stop the statin before pregnancy, and I will resume it after the giving birth.
Okay. And there was a question about how far low would you go, like in terms of the LDL? Are there instances where you will go below 1.4?
Again, yes. Again, if we look at the diabetic dyslipidemia, sometimes is we need to understand that it's not about only the quantity of LDL, but our patients with diabetes, the quality of LDL particles is also at fault. So many of these patients is the dense particles, very atherogenic particles, and we see that many of these patients, when you look at their LDL, it's only 2.4, even 2. I have patients who have a 2. And to say to that patient, okay, I'm going to give you a low intensity, a 10 milligram of atorva, it will get you to 1.7. I don't think we are doing any favors for these patients. And this is really why the guidelines are now saying, remember, and I think again, Dr. Underberg, he mentioned that repeatedly in his presentation, that modest reduction of LDL is not going to bring about the benefit. So there, the 50% is extremely important. So a 2.2 becomes 1.1. So again, we need to remember that very well in our patients. And to get that down to 1.1, the 50%, you really need, in many patients, high intensity with or without combination treatment.
Excellent. Thank you very much. So for the sake of time, we will conclude now so that we can get you back to what you were doing. I really do appreciate the time that all of our participants have spent with us. I would like to thank everybody for spending their weekend, or at least part of their weekend, with us. And I'm certain that you have found it both informative as well as engaging. We would like to thank Amgen for their support in making this possible, as well as MCI for their support. What we would like you to do is that when you get the evaluation form, which will be sent to your registered email, please fill it so that you can receive the CME, which will be available in a couple of weeks' time. So this webinar, there was a question about it that somebody had missed a part of it. It will be available on demand on the EDS website and the YouTube channel. There are other upcoming webinars that you can learn about on our website. So once again, I would like to thank all of you for participating, And please stay tuned for the upcoming EDS webinars, as I mentioned before. So have a nice evening, and thank you very much. Good night.